when you go to America, it is used more as a billing process or a billing machine, more than a clinical information storage system. Then EMR, electronic medical record, is limited to storage and access from within the hospital, limiting to storing patient demographic data, because many of the hospital management information people who are doing the software business, they say, yes, I have an EMR module. Okay, what do you have? Yes, we can locate patient, we can search patients instantaneously. Okay, any clinical data? No, sir. That lab you have to get into the lab module, radiology module. We do typed discharge summaries. Now, we don't believe that much of time is going to be available as we get more and more patients. You need to automate it. Then computerization, primarily meeting the management information or the hospital admin requirements. There is a lot of focus given there, but not to the clinical information system. Now, there is a lot of reluctance to adapt to integrated approach unless it is connected with their billing or collection process. Now, that is where IRDA is stepping in to say that, look, I need your clinical documented evidence for me to pass your bill. Okay, in one way it's good, and one way it's definitely going to delay settlement process if you don't have a proper documentation system in your hospital, which can be accessed without any threat to your hospital's data. Next, please. So, what are the challenges that we face is definitely attitude. Okay, the attitude of doctors, attitude of patients, attitude of nurses. Well, here I am trying to put bureaucrats and government, because I am trying to address it as a national level or even internationally. This is a problem with the attitude. Then approach, it's still not a very positive one. People always look down upon when we say that, okay, you guys, you create something and you try to come and sell it. No, there is never going to be a situation if someone is going to come and tell you, I have a ready-made solution, I can put it for you. It's not going to be possible. Then there is a lack of vision and creativity. In fact, I would like to quote a very interesting article from the BMJ. There IT goes again. I can get you the reference. Here the very interesting thing is there has been a complete threadbare analysis of the NHS program from almost 1990 till 2011, where they have analyzed many programs, attempts to make a paperless system or an electronic medical record system, and why it failed. In fact, they have directly linked the cost of the budget is more than the failure rate is much higher, for a very simple reason. You need to have a lot of commitment and creativity when you are creating such a system, which is predominantly lagging in the top companies, because they don't have expertise and core domain commitment in that area. Of course, affordability, yes, we all know it's quite difficult, but still I think many of us know that iPhones sell much more than any other phone in the world. It's not cheap. Acceptability, now that is something to do with all the other above points, whether it is from the individual patient or a doctor, as I told you earlier, or from an institution level, be it government, be it private, it's a problem with the acceptability level. Then adaptability, there is a lot of problem in willingness, and they don't get the motivation to get into new technologies. We all like to use the latest mobile phones, latest televisions and latest gadgets, latest cars, but we don't want to see what is there, because this is going to, what we say is, if there is no health, there is nothing in life. Now here technology is there to keep you updated about your health, and which can be accessed from anywhere in the world, where during emergency or non-emergencies, it definitely works. So we need to get closer to adapting it. Security and confidentiality is a very subjective problem, because how much ever we say, definitely there is going to be an element of doubt. But I can tell you one thing, today's technologies have become really robust, it's quite dependable, and people on cloud computing have put a lot of things and it's working. You don't need to have anything. You have a tablet, you just have an iPad, you can access any information from anywhere in the world. The complex codes and differential standards in health system, well, we can't do anything about it. Each country, each state has its own standards and codes. Unless or otherwise we sit through an international conference to arrive at a consensus, nothing can be done about it, but still we can customize it to match to that state and that territory's requirements. Next slide, please. I have a change in approach because the first time I met Dr. CVK way back in 1999. So he said, Venkatesh, I appreciate all that you are talking, but the problem is I never like to get closer to the tail of a mouse. Now you promise that you will never take me closer to a computer. I will see what I can help you. Now that is, that was Dr. CVK in 1999. Now this is 2011. Now this is, I will tell you, this is not a planned photo shoot. I think Dr. Prema is there. She was also there during that day as he was explaining a patient. You can see there is no mock screen there, it is a real screen with a tabulated data. He is using the computer, touching it physically, right, and then explaining something to the patient. Now what you see on the other side of the screen is British Medical Journal says, should patients have access to their individual medical records? I would say, or anybody would now say a big yes, because the patient should know about their condition and they should be involved very well in the care process. Next slide please. As you know, many a times when we attempt to give a demonstration, the Murphy's law works very well. You know, when you need it the most, any technology, how much ever you have done your pre-planning, it will fail. Well, this is the Australian High Commission people. They had come down for a visit to TAG VHS on 13th December 2011. Now what this gentleman said was that I am happy your demo did not fail. So that means your system is really working. So, okay, next slide please. Now how do we do this planning and approach? I am just going to quickly run through. Whenever you plan things, you need to plan for contingencies and issues, because when we made TAG VHS a paperless hospital, when I planned for the hardware networking, in fact I was scolded by many people that you are overdoing your job, you are planning it more than what it is required. But remember, we have had at least about half a dozen times rat bite cable connections, and when the cable system had failed, it is a wireless system that helped us. So when desktops did not work in billing or reception or in doctor's chamber, we could substitute with laptops with wireless connections, which instantaneously could connect to the system and give data. So planning your hardware, software, networking or connectivity, and consistently upgrading the system. Continuous training and support, because you cannot say I have got a team of people, I am going to train them and they are going to support me forever. No, once they get trained, they look for another job and they keep going. So there has to be continuity in training. Then interoperability and seamless integration with the existing. Now if I am going to get into a hospital and say, okay, now today I am going to be here, put all your computers, existing ones, in a gunny bag and throw it into the Bay of Bengal. I am going to set it up all new. No, it is not going to work. So interoperability and seamless connectivity with your existing system and slowly migrating to a new system. That is how things will work. Then what is the future scope? What is our vision? So we educate people. Now this is how you should look at. Now the vision is very simple. I am not going to waste paper. That's all. No paper will move inside my hospital unnecessarily. The only paper that will go is a prescription or a summary or a receipt to my patient, but inside my hospital I will not use a single paper. So that is the ultimate future scope and vision. Next slide please. So the advantages, I don't want to, and I think we have handled too much of it, but I am just giving it to you for you to read through, and the presentation will be up tomorrow morning in our website. You can have a look at it. Next slide please. Now this is a real time scenario, because the most difficult people to make closer to computers are not doctors, because if I could make Dr. CVK, it was very good. But now the very interesting part is nurses. You can see the nurse here with an iPad during the rounds. We don't have a filing system. Well, what you see as a paper there is actually not a case sheet or something. Normally when Dr. CVK comes, he always comes with a big bag full of papers. The problem is, many of the journal articles he photocopies and keeps it with him. If somebody has a problem, he does not just tell it by say don't use this. Now he pops out evidences, clinically proven evidences to the patient and say, look, it is given here, don't take this drug. So that is something to do with such a photocopy of an article, not our case sheet. Next slide please. Now this is the most important point, because this is going to provide a lot of opportunity to unemployed youths, qualified people, semi-skilled people to be made skilled and made employable. Now we have taken that as a vow that we will help people who are having commitment and interest, who wants to make a career in this sector, because let me be very frank, it's not going to be too long before you will see the medical transcription industry will die, because it is not going to be economical, it is not going to be affordable. So you need to know how to do your job. So instead of sending it to another country as a voice and getting it as text, if you could train people in your own hospital, your own staff, for example, a medical record department has 14,000 square feet dedicated for this in a 600 bedded hospital. A floor space of 14,000 square feet, you know how, in fact tag VHS is only 12,000 square feet. So if you say 14,000 square feet, if you are going to waste for storing files, now we have 25 people working only to pull the files and put it back. Now those 25 people, if you train, you can run a 1,500 bedded hospital without a single paper moving on. So you create a much better value in them rather than merely using them as people who remove and put files. Next slide please. So the future, finally, for achieving the cost effective inclusive healthcare models, we need encouragement and adoption of IT initiatives which over the last 1 decade have proved themselves to be security proof with inbuilt transparency for honest, speedy and accurate analysis, saving enormous time, space and money. Well, this happen in the, will this happen in this decade or this century? But I'm pretty confident someone from this crowd will definitely carry this message, and if you could really think about it, it will happen today. Next slide please. Thanks a lot.
Thank you, Dr. Mr. Venkatesan.
You are now talking about other people wanting to enforce this computerization data and all. Income tax, central excise never did it right from beginning. They have started computerizing.
Absolutely.
Now we find that they find that computerization there makes them a lot of work easier to get more money from people who are not paying tax because they are trying to do everything. So the next question, no offense meant to any of the doctors. If half your services which a patient requires is made service tax, they will force you people, everybody will start coming into things.
We have to give half an hour for people to come back for the other thing. Thank you very much, Venkatesh. At least I am in a better footing, Chris. There are so many people to listen. Not all of them doctors, but all of them are friends, relatives, and others who have come to bolster me up. That's how I carry on. The important thing is, we all know, you have been listening from morning onwards from Professor Hegde to Dr. Girija, that taking too much of medicine is bad. We all know that. But somehow or the other, we have been tuned over the last, say, 300, 400 years to the fact that there is a pill for every ill. Actually, it's Hegde's favorite saying, there is no pill for every ill, but there is an ill for every pill. So this is a fact. An ill happens after every pill, but no pill for every ill. So while we know that, we rush to the pill box, and recently there has been a chorus in international arena. There are a few lone warriors. Fortunately or unfortunately, I have been one of them. Professor Hegde has been another, and the Ayurvedic Pandits have been staunchly educating against it. And there are homeo people, Siddha people. People say they are all medicines. Why are you taking that? Why don't you take this? All the things that are natural or those which are proven to be harmless to the human body are definitely welcome into the human body. All things which act against the human body are definitely rejected by it. As morning professor said, the liver first detoxifies them. You think you have swallowed it. Every pill in the Western medicine or in allopathic medicine is dextrorotatory, and the body cells are levorotatory. So you are actually fighting, you are amongst yourselves. So it's a Ram-Ravan Yuddham. You are going against, tug of war. So who wins ultimately depends on our karma, fate and kismet. We can win sometimes, they can win sometimes, more often the latter happens. So I want to just take not more than about 20 minutes. I'll try to condense, but I'm going to give you our experience at TAG. Like Girija, I'm going to present a few cases to show what really happens. There are people who take huge amount of medicines for very many diseases, because when you think health is absence of disease and the presence of disease must be treated with pills, you start taking pill for every ill. And when that happens, then you cannot stop it, because you fear that I have got hypertension, I got diabetes, I got coronary artery disease, I got arthritis, I got vertigo, I got nausea, I got vomiting, I got hyperacidity. So name one pill for each, you are landed up with a laundry list of 20. And you take it every day religiously, morning, noon and evening. So these beget their own side effects and their own counter reactions, and you are ended up with a mess. So to avoid it, how to avoid it is what one of the chief aims of TAG VHS. And we started this computerized data, and it is very revealing. The computerized electronic record at a moment can give us what we did when these people came and what is the result. I'm just going to share this with you and then show you how the whole world, whole Western world, which was advocating all this, has now turned into screaming in banner headlines. So much so, they are going to have a conference in Dartmouth, South Carolina in September this year on a subject called overdiagnosis and overtreatment in today's medicine. That is the title. There is going to be a conference organized by the British Medical Association along with the Americans. So they have come to know what we have been telling for last 40 years. So I just want to share with you our experience at TAG on our observations of how people come to us and what happens to most of them. And that I must really thank only Mr. Venkatesh for us being able to take out the records in record time, because the entire conference was organized in 2 weeks' time. Next, please. See, the latest, one of the most recent BMJs in the form of an iPad, overdiagnosis harming the healthy. As Professor Hegde pointed out in the morning, the moment you go to the doctor, you become a patient. Until then, you are not a patient. You do a master health checkup, there are 6 diseases. Many of these diseases are now called incidentalomas. That means a loma is a tumor or a swelling. If there is something there, it becomes a disease, so you either want to biopsy it or take it out or see what it is, because the fear is always there. Otherwise, another 40 years, the tumor would have been remaining there. So this is overdiagnosis harming the healthy. And these are very, very senior research people. And this is the chief editor, Fiona Godley. And winding back the harms of too much of medicine. That is what now the aim of most of the Westerners are. Fortunately for us, we have got the Indian wisdom of various other systems of medicine. So if we adopt all this system holistically in one center, in every center in the country, I'm sure our nation will be the torchbearer in health issues in the entire world. That is the firm belief with which our research center was started, and we are going ahead with all your blessings. Next, please. So Fiona wrote last year, middle, concern about the harms or the costs of overtreatment is gaining momentum. Overdiagnosis is actively harmful. New technologies that are ever more sensitive can diagnose abnormalities. They call it incidentalomas. And then there is a man who says, Yudkin, who is a very big physician, he says, overdiagnosis of diabetes. This I must spend a little time. One of the barriers for appropriate care. How do you overdiagnose diabetes? By simply lowering the blood sugar values for diagnosis. You say 140 milligram blood sugar is normal. Then the people above 140 will become diabetic. Then next year, some people get together and say, oh no, there won't be enough diabetics for us to treat. So make it 130. So make it 130. all this, don't laugh because this has happened. This is what this fellow has said. Andrew Yudkin has said, John Yudkin has said, fasting blood sugar in pregnancy should be less than 90. Otherwise, you are diabetic. So you get gestational diabetes, hundreds of cases. So you treat them. So these are all actively happening. Another very interesting thing I'll come to a little later, not now. We can increase diabetes to whatever we want. How do you think all these diabetologists, sir, I want to exclude myself, predict that? No, how do they predict? We are going to get 62 million diabetes by 2030. Can you all tell me? How? No, they know how. I will show you. When the time comes, in another 2 minutes, I'll show you. I can predict because I know what I'm doing. What is causing diabetes? We'll come to that. So, this is the thing. And I don't want the numbers who will fail to benefit from glucose lowering are likely to be even larger than in the lower risk population, such as the one diagnosed by screening at a lower diagnostic threshold. That's what I told you about the gestational. Next, please. In America, there is a paper last year, 2011 November, where seniors above 65 or 75 who are sent into ICU, 80% of them, how they responded. This has been given by a man who was the the Center for Disease Control at Atlanta, and he has given this. So 8.1% of hospital admissions occurred amongst patients at least 80 years and above, and 65% of them were caused by drug overdosages. Can you believe it? After 80, what is the need for so many medicines? And you take so many medicines, and 68% of them were admitted due to drug overdosage.